In this module, we will discuss the protocol for implant placement. And for the example, we will be using 4.0 by 10 Dentis SQ implant. A 4.0 by 10 implant, if you look at this implant drill tray setup, here is a fixture of 4.0. The length goes from 7, 8, 10, 12, and 14. Therefore, a 10 millimeter and go and cross into this 4 millimeter, that is the proper target. That is the ultimate or the final drill needed for this implant system. However, there are certain exceptions to this rule that we have to understand fully. If you follow that logic and place the 4.0 by 10 and do the osteotomy exactly by 4.0 by 10, the implant will be at equicrystal. It will be equicrystal. We advocate to place the implant at least 1 or 2 millimeters subcrystal. So instead of 4.0 by 10, I usually drill down to the 12 millimeter level, so I have at least 2 millimeters of leeway to place the implant 2 millimeters deeper. The second factor I have to factor in is I want the implant to be as tight and smaller osteotomy as possible. So oftentimes, although I am placing a 4.0 implant, I may consider undersizing to 3.5. And that is common for all the implant series. Even though I might be placing a 5.0 implant, I may want to use 4.5 drill as the final drill, especially in soft bone. If the bone is very soft, such as in the posterior maxillar, I may even downsize 2 levels of osteotomy in terms of hole size, width. So 5.0 implant might be placed into 4.0 osteotomy. And let's face it, even though you might be drilling at 4.0, depending on the hand movement, the accuracy and so forth, the hole might be way bigger than 4.0. It might be close to 4.5, and therefore the 5.0 implant going in may not even be tight at that level. So going back to this 4.0 by 10, the first drill is typically one of the spear drills or a starter drill. Now, we advocate using piezoelectric surgery device or a simple round carbide burr. You can always use a Lindemann burr if you have started a drill and then you may want to move it sideways, and Lindemann drill is exactly that. It's a side cutting drill that has sharp edges, cutting edges on the side. So once you have established the initial dot to start the osteotomy, the first thing you do is go to the 2.2 millimeter length or the depth determining drill. So again, for the 10 millimeter, I would first go to the 10 millimeter, verify the depth, and perhaps use a guide pin of sort to be able to see that your initial drill is exactly where you want. And here's another variation of the guide pin. This one corresponds to the 2.2 drill. So after the 2.2 drill osteotomy, you put in this device and verify the direction. If you are happy and satisfied with the direction, then I would advance to the 12 millimeter. Given that there is anatomical allowance. If the nerve is too close, if we have too close to other structures, be careful. But given that the length determination was correct, go all the way to the 12 millimeter, even though you're drilling for the 10 millimeter implant. Then, depending on the density of the bone, you could go to this pilot drill. This drill is a very special drill. It is a 2.2 to 2.8 pilot drill. It has a step. If you look very carefully on the top, approximately 3 or 4 millimeters, it is a 2.2, and it transitions into a 2.8. So it guides you from this hole to the next hole without abruptly changing the directions. So once you have established that, and again, the depths will be determined by what initial depth you've created. So in this example, we went to 12. Now you take this one. Initially, the 3 millimeters will be passive, and then the further 9 millimeters or so will be active as it cuts through with this wider part of the drill. Then that will give you the establishment to go to the next drill. And again, because we were already at 12, you're going to jump to the 12 millimeter of the next size up. So this drill comes into play. So this drill will be going all the way in, and these dentist drills have tapered design because the implants are tapered, but they also have very distinct drill stopper. It is actually wider at the exact depth so that you cannot go any further. This is clearly at 12 millimeter, so you cannot advance more than 12 millimeter even if you wanted to. So this is by design. Once you have done that, then I would look at the osteotomy, take that implant and drive it in. If halfway through the driving in process, if you feel significant resistance, do not hesitate. Back out the implant, put it back into the vial, and then drill more. You may have to go to the final drill, but many times, especially in soft bone, that should be the final drill, and you should be able to torque the implant in with significant amount of initial stability torque. Do not follow the advice of don't place implants higher than 30 newtons. You are more than welcome to place implants at 60, 80, even 100 Newton centimeters, so long as you do it wisely. In this module, we will talk about some of the basic principles of implant drilling or osteotomy process. There are many myths and misunderstandings in this very simple procedure. The first thing I'm going to say is the implant drill, the implant handpiece, and the whole motor setup is rather heavy and cumbersome. We are not very used to using very heavy devices like this. As dental clinicians, we are usually accustomed to rotary handpieces that we use with paint motion. When we prep a tooth, we use a lot of this brush motion, very, very fluent and artistic hand movement, which is something we are born with, and we're trained like that for many years. When we transition to implant drilling, it is a completely different ballgame. You are not allowed to move around. You are supposed to have a firm grip. You're supposed to have a firm fulcrum that's stable. And then all the motion that you need really is just unidirectional. Straight in, straight out, without any variation. If you make any subtle changes in the angle, the osteotomy is not going to be produced with very cleanness. So in this example, going through a osteotomy here, take a look at this example. If I go straight in and straight out, you will create an osteotomy that's ideal. However, if I'm hesitant, and if I'm going in with a little bit of hesitancy or uncertainty, the drill will become a very dangerous device, ending up with much larger hole than we desire. Something as simple as using a hand fulcrum, which is highly desirable. If I use a hand fulcrum, and if I'm not careful, if I'm doing this, then it will also create a very unusual osteotomy. So the actual osteotomy needs to be straight in, straight out, straight in, straight out. So how do you do that motion and still have a intra and extraoral fulcrum? That is the topic of challenge. So here is a real life situation. We're doing an implant in the upper left bicuspid. Typically the cheek will be somewhat like so. So you'll have an assistant helping with the retraction, and let's say we get good visibility. I'm going to afford an intraoral fulcrum, assuming the patient has anterior teeth, and this fulcrum will actually give me the reason to be stable. So long as I'm not using a swing motion, if I can go in and out, that will help me tremendously. However, the in and out motion is limited by how much motion I can make. Physically, the depth. Let's say we're drilling 12 millimeters. The whole hand apparatus, my hand, the implant handpiece, the drill, the whole apparatus has to move uniformly 12 millimeters and 12 millimeters out. But when you have fulcrum, how can you do that? Because the fulcrum causes a pivot point to the point where you rotate around that area. That is an important point. So the key thing is drilling needs to be a two-handed procedure. The operator needs to use both hands. The assistant has to stabilize the cheek, suction, retraction, all of those. And it's always helpful to have a second assistant because we always run out of hands. And then the operator needs two hands. We need two hands to be able to use the left and the right hand to wrap completely. And then many times I'm using an extraoral support as I use initial finger fulcrum on the tooth there. But really it's the extraoral. My hand might be resting on the patient's zygoma, cheek, or buccal side, and the whole left and the right hand is moving in and out in this manner. Otherwise, we could easily get trapped into the rotary movement that causes an unwanted angle. So here we go, just to simulate. I've got the motor running, and this is the kind of motion. And this is where I would like to introduce this concept called bone dance. Bone dance is a term that I learned from my late mentor, Dr. Carl Misch. Here's the essence of it. When you advance, there's a point where you start to feel resistance. Hopefully it's a resistance at the end of the burr, not at the side, because you're really going in very parallel. And when you start to hit the resistance, so if the drill is starting to hit new bone that was not cut previously, then you try to feel for the density. So you're advancing a small amount, say a millimeter or two. And when you feel that resistance, because heat will get generated, the bone mud will pile up, that's when you back out. Let that irrigation take care of it, let the bone cool and relax, and then repeat. Go back into the same spot and push hard for that extra millimeter or two and repeat. So it has to be a rhythmic thing, but you have to be careful. Every time you advance and back out, you don't want to have any flaring movement because that will cause a funneling. The hole will become wider at the top and smaller at the base. So that's what Carl Misch called the bone dance, like a waltz. You're going in, you hit the bone, feel the back up, let the irrigation do its job, go back in, hit the bone, go back in, hit the bone, go back in, and we're getting very close to the end. And as we hit to the stopper and it stops, I rapidly remove as to not create this funny, unwanted shape of the hole. So that, in essence, is what's called the bone dance.